It's an important topic in pediatric endocrinology, increasingly relevant, and it requires early recognition and appropriate evaluation to optimize the clinical outcome in children. So it gives me immense pleasure to introduce the speaker for today's session, Dr. Swati Kanodia. She's a consultant in pediatric endocrinology at Madhukar Rainbow Hospital and BLK Max Healthcare. Ma'am has extensive experience in the field of pediatric endocrinology, and she'll be sharing her insights on this topic. So without much delay, I invite Swati ma'am to begin her presentation. Welcome, ma'am.
Thank you, Dr. Aarti. And good evening, everyone. And I hope we have a good interactive session about the topic, which is very relevant to these days. I will just share my slides and then we will talk more. Yeah, so can you see it? Okay. Right. It's okay. Right. So today we'll be talking about the pubertal disorders in children. So what I want to speak about is what are the common things that we need to know about puberty? What is early puberty? When does it start? When do we call it early puberty? What are the different, let's say, the causes which can cause early puberty? When do we call it to be real early puberty? So these are some of the questions that you should know the answers to, because this is something which we are seeing in our day-to-day practice quite a lot these days. And what has triggered early puberty in children these days, we are going to talk about that also. Right. So as you all know, that what do we call puberty in the girls? It's the appearance of the breast bud. We do Tanner staging, which we call it as stage Tanner 2. And in boys, testicular volume of more than equal to 4 ml. So how does it work? As we all know, from the pituitary, LH and FSH are secreted, which go and act on the gonads in males and females, from where estrogen and testosterone are secreted and which bring about the changes in the body. And our gonads, which are responsible for the pubic hair, the body odor, acne, those things. So we call it as peripheral signs of puberty. Okay. And the ages that is determined, when do we call it, like, the normal age of starting of puberty in girls, it is 8 to 13 years, and in boys, it is 9 to 14 years. Although the paradigm is shifting now, because we are seeing more and more girls starting with their puberty between 6 to 8 years of age these days. So although the official definition is this, but I think probably the definition is going to change soon. But right now, this is what the definition we take. And what is precocious puberty? If you take it by definition, then pubertal status less than plus two standard deviations for ethnicity. This actually practically does not hold any meaning for us. So what it actually means practically is that in boys, any changes or increase in testicular volume before 9 years of age, and in girls, any sign of breast development before 8 years of age, periods before 9.5 years of age, or the gap between the starting of the breast development and having periods is less than 1 year, then all these are called as early puberty or precocious puberty. Okay. So now what are the causes in boys and in girls? So there are two types of causes in boys and girls. One is gonadotropin independent which is called as peripheral precocious puberty, and another is gonadotropin dependent, which is called as central precocious puberty or true precocious puberty as we call it. Okay, so in the girls also we have similar. So now basically in gonadotropin independent is the one where actually the pituitary is not involved. So it has external causes. In boys, it can be usage of testosterone creams. It can be adrenal causes where CH is most common, and it can be testicular or gonadal cause. Okay. And in central precocious puberty, it is the pituitary which is involved, which can be either because of a tumor or a trauma or a surgery, something like that. In the girls also, gonadotropin independent, again, we have either the estrogen estrogenic ovarian cyst or tumor or CH or primary hypothyroidism. I'm going to show you how primary hypothyroidism can also actually lead to early puberty. And gonadotropin dependent is again pituitary related. So how does it work? I will just show you. So this is the central and this is the peripheral as we have divided it. So most common cause is central is idiopathic, or it can be a tumor or CNS insult. And in peripheral in boys, it can be a tumor or testotoxicosis. Or in girls, it can be hypothyroidism, ovarian cyst, or McCune-Albright syndrome. These are the most common causes as we see. And in adrenal, it can be a CH or tumor. Now, something is there in called as complete variance, which is something that we should be aware about. This includes either just premature thelarchy, which can be palpable glandular tissue in girls. Usually it is seen in less than 2 years of age. Now, in this, what happens is that, as we all know, there is something called as mini puberty, which occurs in both boys and girls, okay, in which the hormones are secreted in the first 2 years of life, or from 6 months to 2 years of life, and then they subside, and then the hormones are formed again once the child reaches the age of puberty. So now, because of that, there can be some palpable glandular tissue in girls, which can be present either from birth or from 6 months of age. It is usually non-progressive, okay? And it is the bone age is normal, the blood tests are usually normal, or there might be a slight increase in estrogen levels that you might find, but the growth rate is normal. It is very, very important to rule out lipomastia, because when you make a child who is a little bit overweight or plump, make a child sit, the chest would pop out and it would look as if there is a breast development. So it is very, very important that obesity is ruled out, and we just do not label it as early thelarchy or precocious puberty in a very small child. And there is something called as premature adrenarche. This is usually seen in 6 to 8 years of age group, and this we are seeing quite commonly these days. So there is appearance of pubic hair, axillary hair, body odor. Mild acne might also be there. So, but the growth rate is normal. The bones do not, the bone age maturation is normal and according to the age and the height of the child. There is no evidence of clitoromegaly or penile growth or testicular enlargement. And on investigation, you might find that the DHEA is raised, but LHFSH, estrogen or testosterone levels would be pre-pubertal. And this is called as peripheral precocious puberty, not true puberty. And there's something called as premature menarche, which is very, very uncommon. We usually do not see this. So if you find this without any other signs of puberty, there is no breast development, there is no hair, and the child just presents with menarche, then it is very, very important to rule out local causes. That is in trauma to the area, foreign body, abuse, or there is any, vaginal or uterine tumor is there or growth is there, that is supposed to be ruled out. Now, why do we talk so much about a child starting puberty early? Why are we so worried about it? Why are we talking so much about it? It's a natural phenomena. Let it occur. How does it matter? Anyways, a child has to undergo puberty anyways. So whether it happens early or late, how does it matter? Why it matters is that starting and completing puberty too early may prevent a child from reaching his or her full adult height. Because as we all know, that the hormones which bring about the changes in the body, the same hormones tend to mature and fuse the bones. And once the bones are fused, the person stops growing in height. So if you start puberty early, so you are having the changes which you're supposed to have at 11 or 12 years of age, you're having at 8 years of age or 7 years of age. So once you start developing, you're going to finish developing early also. So the height potential that you're supposed to have you will not achieve because the bones will fuse earlier. Another thing is that we might miss out on an underlying pathological cause which might be causing early puberty as one of its symptoms. Okay, so there are a lot of pathological conditions which can present as early puberty, which might be missed out if we do not investigate and just take it as a natural, normal phenomena occurring early. And the psychosocial impact of premature sexual development is very, very important because a child's mind and body might not be ready for the changes that are happening, and it may cause a long lasting impact on the child's development and brain and thinking process. So everything should happen in its right time, and the child is mentally mature enough to handle body changes, to handle periods, to know about good touch and bad touch, and not get abused, not get attracted towards watching wrong things just because the mental maturity is not there. Okay, so now, as I was telling you about that, sometimes by wrong examination, things can get complicated or might get missed out. So we have I'm going to explain most of the causes that can cause early puberty through cases and examples so that you can see how practically these things can present. 6-year-old overweight girl, parents were concerned about increasing breast size. This is how she looked when she was in the sitting position. And she was labeled as having B2 breast development Tanner 2 staging with no pubic hair or axillary hair. Investigations were done, which all turned out to be prepubertal, bone age of 7 years, behind, considered to be normal in any child. Okay, unless it is progressing very fast. Height age of 6.5 years. So she was labeled as premature thalarch. And child was observed for 6 months. There was no change in breast size and height velocity of 6 centimeter per year. As we know that from 3 years to 10 years or till they start their puberty, we expect a growth velocity of 5 to 6 centimeters per year. Now, that same child was seen in lying down or supine position. So it was found that there was no breast tissue present. It was lipomastia. The child was overweight, because of which it appeared that she had breast development. The child was observed for 6 months with lifestyle counseling. So what we can avoid in this situation is the unnecessary mental stress that we are causing to the parents by thinking that the child has started developing early, and we can avoid these unnecessary tests which are not required if we examine the child correctly. Okay. Now, let's take another case. 6-year-old girl, she presented with hilarchy, and as you can see, she's quite tall, and the weight is also quite high for her age, and her height age was of an 8-year-old. On examination, she had breast development, had pubic hair, axillary hair, and her bone age was of 11 years. She was a 6-year-old girl. Okay. 6 months back, her height was 122 centimeters and currently 127 centimeters. So it comes out that her height velocity is 10 centimeters per year, which is much more than what we see at this age. So clearly, the child is in puberty, precocious puberty. So whether we call it central or peripheral, so as there is breast development present, as its height is rapidly progressive, as the bone age is advanced, so this is a central precocious puberty. Okay. Now, another case, we had a 3.5-year-old girl. She had pubic and axillary hair for 6 to 7 months, had vaginal discharge, and as you can see, she was quite tall and overweight. Height age of a 5-year-old. On examination, she had lipomastia, she was overweight, had pubic hair, mild clitoromegaly, and her bone age was quite advanced. It was almost double of her age. Okay. So investigations were done, thyroid and everything. Do you think thyroid should have been done in this girl? Should we do thyroid or should we not do thyroid in this girl? So ideally, hypothyroidism, chronic hypothyroidism, which can lead to mimicking puberty, in that you will find a short and fat child. A tall and fat child is very unlikely to have hypothyroidism as a cause. Because hypothyroidism, if it is very chronic, the TSH levels are very, very high, it is going to restrict the physical growth of the child. So that is why in a tall and fat child, highly unlikely that hypothyroidism can be a cause. Okay. As the child had clitoromegaly and pubic hair, there was no breast development. So peripheral causes were thought of and 17-hydroxyprogesterone levels were done, which were high because 17-OHP more than 2 nanogram per ml is abnormal and should be investigated. So as the child did not have any signs of classic CAH because she presented very late and did not have any electrolyte abnormalities, the diagnosis of non-classic CAH or simple virilizing CAH was made. Okay. And in this child, because they were not very good in follow-up, they did not take the treatment of CAH properly. This child had central precocious puberty because of the constant high androgen levels in her body. The peripheral precocious puberty led to central precocious puberty. So in this child, apart from giving treatment for CAH, we had to give GnRH analogs also to stall her puberty. So we had an 8.5-year-old male child who complained of lethargy, poor school performance, constipation, poor growth. On investigations, the thyroid levels were very, very high. On examination, dull-looking child, and as you can see, the height and weight both were poor. Height of a 6-year, 6-month-old. Goiter was also present. Now, when we examined the child, what we were not expecting was to see that there was pubic hair present in an 8.5-year-old male child and the testicular volume was high. And when we did the investigations, the LH, FSH were in puberty range and testosterone was also high. But the bone age was only of a 5.5-year-old. So what is this? This is called as von Wieck-Grumbach syndrome. This happens in chronic hypothyroidism because the TSH and FSH have similar alpha subunit. So because of very high TSH levels, the FSH receptors get stimulated, which leads to increase in the testicular volume, but it is not central, it is peripheral. So the actual puberty is not there. It is peripheral kind of a puberty, which can occur in these children. So when we treated this child for hypothyroidism, although the testicular volume did not go back, it remained where it was, and this child started the puberty at its normal time. Now, we had a 9-year-old girl. She came to us with severe pain abdomen, and when ultrasound was done, she had huge ovarian cysts, right of 131 cc and left 456 cc. And when we asked the history, the mother told they had come from Bihar, and mother told that the child has been having regular periods since 5 years of age, and they didn't think anything about it. And she was severely constipated, dull looking child, and a 9-year-old child had a height of 102 centimeters only. As you can see, she was very, very short and she was little bit plump and bone age of only 3.5. So she was 6 years behind than her actual age. And on examination, there was no breast development, no pubic hair, dull child, cold extremities, chubby looking child. She's a 9-year-old who looks like a 4-year-old. When we investigated, the TSH was more than 1,000. LHFSH was pre-pubertal, they were not high. Estrogen levels were high, prolactin levels were high, cholesterol levels were high. Now, these all can happen because of chronic severe hypothyroidism. And when we did an MRI, there was an enhancing lesion in the suprasellar region, which is called as figure of 8 appearance, as you can see on your screen. This is because of the pituitary hypertrophy. Why hypertrophy happens? Because of the chronic stimulations of the thyrotropes in the pituitary, because of the very high TSH, because the FT3, FT4 are low. So the brain is constantly being asked to produce more and more TSH. because of which the pituitary thyrotropes, they enlarge in size, because of which pituitary hypertrophy happens and this figure of 8 appearance happens. Now, this child was supposed to be taken for surgery as she had come with severe pain abdomen and it was an abdominal emergency. But when the surgeon saw the TSH levels very high, and we requested the surgeon to give us some time to normalize the TSH levels before we think about surgery, and I'm very glad that they agreed to it. And within 2 months, this child's ovarian cyst had come to almost 45 cc, and the TSH levels had come down to normal. Her height had started increasing. She had severe muscle spasms, which had happened when we started with the treatment, which slowly subsided. And she started talking, she started interacting more and everything. And now, currently, this child is 13 or 14 years of age. And we had to give her some growth hormone because she was very much behind in her height and everything. And these children, what the problem happens is that because they had shown some signs of puberty because of the high TSH levels, the receptors do get stimulated. And so they do have chances of going into puberty early. And because of which we sometimes have to stop their puberty for some time to give them time to grow. And all these parameters, the prolactin levels and the cholesterol levels, they came down to normal just by treating hypothyroidism. So this is again an example of von Willebrand syndrome. Now, we had a 4-year, 8-month-old girl. She came to us with vaginal bleeding since 3 to 4 days. And the growth was normal for her age. She had a big cafe au lait spot from right torso to thigh. She had a breast development of Tanner stage 2 to 3. There was no pubic or axillary hair. The bone age was not very advanced. It was quite same to her age and height. LH was prepubertal, FSH was prepubertal. Estradiol levels were quite high. And on ultrasound, the right ovary had a 12 cc cyst. Now we suspected that this child might have McCune-Albright syndrome because they can present with cafe au lait spots, fibrostosis, and repeated ovarian cysts, which can ultimately lead to early puberty because of the constant stimulation by high estrogen levels. So in them, what it happens is the cyst develops, child estrogen levels rise, the cyst ruptures, child has a bleeding like a period, and it resolves by itself. And it can happen once in months or once a year, depending on what the genetic variation is. We lost this child to follow up, so we do not know exactly what the diagnosis was. Now, this was a very interesting case that I saw. We had almost a 5-year-old who came to us with pubic hair since 8 to 9 months, darkening of the upper lip area, and there was thickening of voice. On examination, he was quite tall, weight was high, height age of 7 years. Pubic hair 4 to 5, testis was enlarged, pubertal, bone age was ahead, almost double the boy's age. LHFSH were clearly pubertal, testosterone was clearly pubertal. We again thought of hypothyroidism might not be there because the child was not short. So we investigated everything possible that we could. We checked the MRI because in boys, any boy who presents with early puberty, they have higher chances of having a pathological CNS cause behind it. So in every boy with precocious puberty, MRI must be done. It was normal. We looked for McCune-Albright syndrome features. There was no cafe au lait spot, no fibrostosis. There was nothing we could find. We did genetics also, which turned out to be normal. We treated this child with GnRH analogs. He responded to the treatment. I stopped the treatment when the child was 10, 11 years of age. Until that time, the child responded. So it was precocious puberty, but we could not find the cause, and in a male child, which was highly rare, I would say. So this was a case of idiopathic CPP. Now, what has been the impact of COVID on early and precocious puberty? We have seen a rapid surge in both CPP, that is a central precocious puberty, and rapidly progressive puberty, that is the puberty starting at normal time but rapidly progressive. Both have been seen since COVID and during COVID, and we do not know whether there is a direct effect of the infection But there is a hypothesis that both physical and psychological factors related to the pandemic seem to have a role in triggering the GnRH pulsatile secretion, leading to early pubertal onset. And also in children who are starting with their puberty early, it has been found that the BMI increased significantly during the lockdown, and families reported an augmented use of electronic devices. So we do not know what exactly the cause is, but there has been a surge since COVID. So how do we evaluate these children who present to us with early puberty? So we need to know the duration, that if it is, the duration is short and rapidly progressive, again, that might be a central precocious puberty. Family history, mother's menarche, father's growth spurt. This is important because the parents who have had early puberty, the children have increased chances of developing early puberty. Is there any exogenous source of sex steroids, any OCPs the family is using, or testosterone creams, estrogen creams that the child might have an access to, or steroid creams being used for various purposes? If there's any CNS symptoms like headaches, visual defects, any history of tumor, meningitis, irradiation, trauma, anything is there, or a history of disorders associated with CPP. Is this really precocious puberty? Very, very important to find out that we do not confuse peripheral precocious puberty with central. So for that, rapid linear growth crossing percentiles, as I told you, that the growth velocity would increase than what is expected at that age. Then changes in the body structure, which we can find out by Tanner stages or by using an oxidometer in males for seeing the testicular volume. Boys, there's voice change, acne, facial hair, pubic hair, axillary hair, body odor. As I told you, it's an adrenal androgen effect. And if it is only these things are present and there is no increase in the breast in females or increase in testicular volume in males, then we term them as peripheral precocious puberty. Vaginal mucosa not checked very frequently, so it's pale. There is estrogen exposure. Now, investigations. What investigations do we do? LH is a better indicator of central precocious puberty than FSH. Less than 0.1 is clearly prepubertal. More than 0.6 is clearly pubertal. Estrogen more than 10, testosterone more than 30. GnRH analog test is considered to be gold standard because what happens is that LH, FSH, and these gonadotropins, they have pulsatile secretion, so they're not secreted in the body at the same way the whole day. Usually they have a surge early morning and they wane as the day progresses, and initially when the puberty is just starting, their secretion can be very variable. So that is why just having one single value of LH and FSH and not done at the correct time of the day might give us false values. So that is why we do a stimulation test in which we give a small dose of leuprolide or triptorelin and we stimulate the pituitary, and then we check for the LH, FSH and estrogen or testosterone levels to confirm whether the puberty has actually started or not. An ultrasound is done to rule out any cysts or tumors and to see whether the changes of puberty have started. Now, pelvic ultrasound is helpful in differentiating CPP from premature thalar as an adjunct to GnRH stimulation. As I said before, all boys with CPP and girls with CPP at 6 years of age or less should have a MRI brain. Now, between 6 to 8 years, if the girls start developing, so it is very controversial whether the girls require MRI or not, because as we said, we are seeing 99% idiopathic cases are there. So, but it depends on case to case, depends on the symptoms, whether you want to get an MRI done or not. So, girls with neurological findings and rapid puberty progression are more likely to have an intracranial pathology and might require an MRI examination. Now, the cutoff values for basal and GnRH stimulated LH for diagnosis of CPP, a lot of different values are being used in different studies, but most commonly what is used is that basal more than 0.2 and peak 5 or more than 5 after stimulation. Now, bone age, it is usually advanced in central precocious puberty except hypothyroidism, in which it will be delayed. Thyroid profile is important, 17-hydroxyprogesterone to rule out CAH, and CNS imaging, as we told, that to rule out any tumors or growths. And treatment, peripheral, we treat the underlying cause. If there is any steroids are being used or any hormonal treatment is being used, we stop the exogenous use. Hypothyroidism, we treat with thyroxine. CAH, we treat with steroids. And ovarian cyst, we observe till we are confirmed about the diagnosis of McCune Albright. And in central, we use GnRH analogs, and the treatment success depends upon the age at onset of puberty, the pace at which the puberty is progressing, and what is the estimated adult height. So the later the treatment is started, the lesser are the chances of success in preserving adult height. And how does it work basically? So what do we do is that we give the GnRH is basically secreted from the hypothalamus, acts on the pituitary, and which secretes LH and FSH. So we are giving the same GnRH in large quantity. So what it does is that it saturates the receptors on the pituitary. So the GnRH from the body cannot act on it, and when the receptors are saturated on pituitary, this does not stimulate the pituitary. So LH and FSH are not secreted, which cannot go and act on the gonads. So estrogen and testosterone are not secreted, and the puberty stalls or stops progressing. And when we stop the treatment, so the GnRH levels go down in the body, the receptors are free on which the body's GnRH starts acting, and again the pituitary gets stimulated, and LH and FSH starts getting secreted, and the pattern starts again. Now we have different GnRH analogs which are used for treatment of CPP in India. Right now we have leuprolide acetate, the only one that we have, which used in different strengths depending on the weight of the child. And triptorelin is also available, used to be available more frequently, but now it's not. And implants we do not have in India currently. Now there have been randomized trial of whether a 1 month or a 3-month depot is better in treatment of CPP, and it was found that all depot preparations, they are equal and effective in treatment or suppression of puberty, but higher LH and FSH levels were seen with 3-month depot, and the dosage might be higher if we are giving it for a longer duration of gap. And they also did study about the long-term outcomes after gonadotropin releasing hormone agonist treatment in boys with central precocious puberty, and was found that long-term treatment significantly improved the growth potential and final adult height in boys with CPP. So that is why this treatment is very good if it is started on time, the children are diagnosed and on time, and other causes which can cause CPP, pathological causes, are ruled out timely. So in boys, testicular volume is most important. Precocious puberty is less common than in girls, and neuroimaging if a central precocious puberty is present. And in boys, very important to rule out lipomastia, and CPP is more common in girls than in boys. Very important to exclude hypothyroidism in children with precocious puberty and short height. So short, fat child with precocious puberty, please rule out hypothyroidism. It is important to observe the children to rule out every pathological cause, and it is very, very important that the timely referral is done so timely treatment can be given. Thank you. If you have any questions, I'll be happy to take them. And I hope this talk gave you some insight about precocious puberty.
Thank you, ma'am. It was an excellent and insightful presentation for sure. And I hope everybody has benefited from the talk as well. So I think there is one doubt in the box, ma'am, question and answer box. Can isolated penile enlargement happen?
So that is very, I don't think that's very rare for an isolated penile enlargement only to happen and with no increase in the testicular volume. Because see, we do get some children in whom the parents feel that the penile size is more than what is seen in that age group. So that can vary basically. Usually we see people with who have come for that they think that the penile size is not adequate enough. But unless there is some infection or something, usually we do not see isolated increase in penile size.
Ma'am, the second question, somebody had asked for a dose of thyroxine. The question is not complete. So if you can type in the question one more time. Another question, does ambiguous genitalia at birth lead to precocious puberty? Will it be central?
Central. So now basically the thing is that ambiguous genitalia, there can be various causes for ambiguous genitalia to happen, and we term it under DSD. And so disorders of sexual differentiation, there can be various causes to it. CAH is one of the very common causes of having ambiguous genitalia at birth. So usually there is some hormone deficiency rather than having excess in ambiguous genitalia. So it depends on the cause why the ambiguous genitalia has happened, because of which we can predict that whether, how the hormones are going to be. Because as I said, in a child with CAH, if not treated properly because of the excess of the androgens, a peripheral precocious puberty can happen, which can turn into central precocious puberty. And so usually it depends on the cause why the ambiguous genitalia has happened, which might give us a clue whether the child would go into early puberty or not.
Ma'am, the next question is isolated gynecomastia in thin child of age 10 years.
Yeah. So usually again we do not see this in thin children unless they have started with their puberty. We do see very thin guys also coming with gynecomastia, which is quite painful also, and large areolas are also there. So it is important to rule out the pathological cause, because there might be some growth or estrogen producing tumor might be there in boys, although it is very rare, it does happen. So we do an alpha fetoprotein and beta HCG levels in children who we find that the areola size is very large, or they have huge gynecomastia with mostly tissue and less of fat. And but usually it is if there this means, like, the child might have started with puberty. So and this gynecomastia would be associated with other signs of puberty. It will not be there just gynecomastia with no testicular enlargement, with no pubic hair, unless there is a tumor. Okay. And then also you find some signs of puberty because of the excess of hormones being produced in the body. So the thing is that if it is there in a thin child also, it can happen, and it's a normal process of puberty, and usually it subsides when the puberty is complete. And otherwise, if it does not, then the only treatment that we have is surgical that we ask them to do, and lipomastia should be ruled out definitely.
Ma'am, another question, it is regarding thyroxine actually, dose of thyroxine in age groups.
Different age groups.
Different age
So
groups.
yeah, so basically it does vary in different age groups. In newborns, we need to give higher doses, like 12 to 15 microgram per kg per day. That is what we give. And in as the age increases, the dose actually goes down, because the larger surface area and everything. So babies require it more. So that is how we go about. And yeah, it does vary for different age groups. So depending on the thyroid levels also, sometimes if it is a chronic hypothyroidism with very high TSH levels, we tend to start with lower dose and increase it gradually. And in babies, we tend to start with higher dose so that we normalize the TSH as quickly as possible.
Ma'am, the next question is any treatment for breast lump in a 2-year-old?
Yeah, as I said, we have 2 to 3 year olds, females who parents present that the child might have some breast tissue, and they usually say that it has been present since 6 months or 9 months and has been the same since then. So you first of the thing we ask them is not to squeeze it, because when they do malish and all, they tend to squeeze it also sometimes. So it's not supposed to be squeezed. If there is no other signs of puberty, the breast lump is not increasing, and the growth velocity is normal, the bone age is normal, then one thing is that if it's only on one side, if it's isolated, if it's hard, and it does not look like a breast, normal breast tissue, it doesn't feel like, very, very important, please get an ultrasound breast done just to rule out that there is no growth and it's a normal breast tissue which is there. And if the rest of the parameters are normal, we just ask them to observe, and we also observe, we do not do any intervention per se.
Any more questions? I think we are done, ma'am.
Yeah. Mhm.
So, ma'am, on behalf of Sir Gangaram Hospital and Indian Academy of Pediatrics, I would like to extend my sincere gratitude to taking your time out amidst a busy schedule to conduct this academic session. Thanks a lot. And
Thank you
I
for
would,
inviting me.
sure, ma'am, we'll hope to conduct more sessions with you again.
Sure, definitely we should do, because endocrine topics are less discussed, and so we need to do a little more of them, actually.
True, true, ma'am. True. And I would
Yeah.
like to thank all the attendees and for actively taking part in the discussion as well. So thanking you all once again. So not taking too much time, giving the vote of thanks. So thank you, ma'am. Thank you all. Have a wonderful evening.
Thank